Siguiendo con el programa, les presento al doctor Craig Coopersmith. El doctor Craig Coopersmith es pasado presidente de la Sociedad de Cuidado Crítico. También es el primer recipiente del premio Amigo de Cosecati. Es director eh, del Centro de Cuidado Crítico de Emory, profesor de cirugía. Es las asociaciones las que él ha listado que pertenece, la Sociedad de Cuidado Crítico, a Cosecati, también a la Sociedad de Shock. Él es cosilla, creo que han reconocido su nombre, de la campaña de Sobreviviendo Sepsis y nos va a estar hablando de sepsis, pasado, presente y futuro. Bienvenido, doctor Cooper Schmidt.
Muchas gracias. Gracias. Hi again. Muchas gracias. Gracias por la invitación. Ozakati is literally my favorite organization in the world. I am so happy to be here. Um, I want to thank yesterday Aurelia Diaz for translating my slides, and today I want to thank Gloria Rodriguez for translating my slides. I know I talk fast, and at least the slides being in Spanish hopefully will be helpful. So my disclosures are listed here. The things that are relevant are I am the co-chair of the Surviving Sepsis campaign. And in the next version of the Surviving Sepsis guidelines, which will come out in March, I will be the senior author. So we're going to start by talking about the past. So the Surviving Sepsis campaign goes back over 20 years. It was introduced at the 2002 European Society of Intensive Care Medicine meeting in Barcelona with the so-called Barcelona Declaration. It was initially administered by the Society of Critical Care Medicine, the European Society of Intensive Care Medicine, and the International Sepsis Forum. The last group was only for the first version, and it's been SCCM and ESICM since 2008. And the initial goal was to decrease mortality by 25% in 5 years by improving recognition and treatment of sepsis, which is obviously a very laudable goal. So here's the guidelines timeline, because again, we're talking about the past, we'll get into the future. There have been, as you see, I guess there's no reason to use the pointer because there's people all the way on both sides. The guidelines, there have been 5 versions of the guidelines. But as we zoom in a little bit, you can see the guidelines have changed quite a bit. For anybody who's old enough to remember the first version, which I am, the first version was 16 pages, and the most recent version was 81 pages. The first version had 135 references, and the most recent version had 653 references. And so there's a number of sponsoring organizations. You can make an argument that we should be asking Cosecati in the future. It's not just SCCM and ESICM. Actually, I'm going to stop there. Gloria Rodriguez is going to be president of SCCM. And please remember that we ask to get Cosecati to endorse in the future. Talking directly to you, Gloria. So it's a broad coalition of sponsoring organizations that's gone from 11 to 21 in 2021. And it's going to be more in 2026. And actually, the reason that Cosecati fits in so well with who we want to endorse surviving sepsis is we're no longer looking at specific countries. We're looking at entire continents or consortiums or confederations to actually endorse, because this is such a global effort right now. Asking specifically one country, but not another country, isn't fair. So we were really looking for continents or wide variants of the world to endorse them. So here's the methodology, and I'm going to slow down a little bit on this slide. So it might be difficult to see no matter where you're sitting, but the methodology has changed very significantly over time. It went from not having PICO questions to having PICO questions. And I'm going to be mentioning PICO questions for those who don't know what that is. It's looking at a question where you look at a patient or problem, and then an intervention, a comparison, and an outcome. We did not used to prioritize outcomes. Now we formally do. It used to just be the people sitting around the table doing a search strategy. And now it's a team of professional librarians with input from the panel. It used to be that we looked at one database. Now we look at least two databases. It used to be that we used to do something called the approach by Sackett for defining evidence. Now we use grade. We didn't used to have patients involved. And as we might imagine, patients have very, very different takes about what's important sometimes than we do. And so last time there were 11 patients involved. Formulating recommendations used to just be a bunch of us sitting around a table using a modified Delphi approach. And now we use grade approach with evidence the decision framework, which I'm going to explain in a couple of slides. It used to be that we just made a recommendation. Do this, don't do this. And now we actually distinguish between a strong recommendation and a weak recommendation, best practice statements, which I'll also explain. And it used to be we didn't explain the implications of recommendations, and now we do. And so, important about conflict of interest. No members of industry on the panel. Industry has no input into the guideline development. There was industry funding for the first version over 20 years ago, but none since. Nobody gets paid one penny for work on this. All panelists have to complete a conflict of interest declaration, which is managed through an independent panel of past senior officers. So when I was the last version as past president of SCCM, I was in charge of conflict of interest, in addition to my colleague in Europe, Massimo Antonelli. And more recently, we're also focusing on intellectual and academic conflicts of interest. Because if somebody actually writes a study and they're first or senior author in something published in the New England Journal of Medicine, that intrinsically gives them both expertise and the potential for bias. And we don't want to have anybody say, I wrote the study and you should recommend this. And therefore, anybody who wrote the study is welcome to participate intellectually to explain the study, but they're not allowed to vote. Panel inclusivity is a work in progress. So you see here that women represented on the first version 10%, on the current version 33%. That's not where it should be. It should be 50% because half the population is female and half the population is male. But clearly each time it's moving up. Surviving sepsis is a global effort. It is not just North America and Europe. But because of SCCM and ESICM's location, the first version, 95% of panelists from North America and Europe. This time, 67%. Not where we want to be. To be global, we want more than 1/3 of people from outside of North America and Europe, but we're improving. And we want to have at least 33% turnover between each version. So it's important that we have people who were previously on it that understood how we did it before. It's equally important to have new people, so it's not the same old gray-haired people like me, but each time we have new people coming with new ideas and new ways of seeing the literature. So its impact is huge. So in terms of citations, it's been in the 99th percentile, every single version. For those who are younger and use altmetrics, things like Twitter or X, or what it gets on social media, which I don't understand, but a lot of you in the room do understand, it's also in the 99th percentile every single time. So let's move from the past to the present. So if anybody ever says, how are the guidelines done? So you put out this thing that's 80 pages, and I don't understand what you do. I'm going to take you behind the curtain to how we actually do it. So the panel group is broken down into subgroups. Each have a group leader. And I'm not going to read them, but you can see the 7 different groups there are because there's about 70 different people on the panel. Having 70 people to discuss anything is useless. But if you have 10 people discussing, that's useful. So it starts with a small group before it ever gets to the bigger group. And then we come up with a list of possible questions. Our list of possible questions, is about 300. But we don't have money to do 300 questions, and nobody would read a guideline with 300 questions. So each group is based upon a budget that's told how many questions it can evaluate. And then we try to pick questions based upon how important we think they are. if there's differences in practice. So for those who were with me yesterday, when I was talking to our nursing colleagues, when I said, who here does this? And everybody did the same thing. I skipped my slides because there was no reason for me to talk about something that everybody agreed to. Same thing here. If we all do the same thing across the world, there's no reason to put a question in. We also look to see whether it's been covered in the past. And then before we ever do it, we prioritize outcomes we think are important. So obviously mortality is going to be an important outcome, but it's not the only important outcome. And when we're looking at things like long-term outcomes, you know, sometimes mortality isn't the most important thing. And so we say upfront, what are we going to look for the outcomes? Each question, last time 93 questions, each question has a separate literature search by a professional librarian. There's a meta-analysis performed for every single question. There's an evidence to decision framework, which I'm going to explain in a minute what it actually looks like. And then we come up with a preliminary recommendation. And there's different strengths of recommendations. Again, we used to just say, do this, don't do this. But that's not actually how the data works. But sometimes the data are really strong, and sometimes the data are not so strong. And so we have strong recommendations. We recommend. There's a high confidence that the desirable effects clearly outweigh the undesirable effects. But most of the strong recommendations, of which there are very few, are don't do this, not do this. Don't use renal dose dopamine. Don't use head-starch because there's clear evidence that they don't work. Then there's weak recommendations. We suggest the desirable effects are likely to outweigh undesirable effects. And then there's best practice statements, which in the next version is going to be called a good practice statement, which are ungraded strong recommendations when benefit or harm is unequivocal, but the evidence is difficult to summarize or assess using the methodology. An example of this would be don't jump out of an airplane without a parachute. So we will never do a randomized controlled trial in which half the group jumps out of an airplane with a parachute and half the group jumps out of an airplane without a parachute because it would be unethical to do. And so we can't grade that evidence. And yet we all recognize if we had to jump out of an airplane, I don't know why we would. But if we had to jump out of an airplane, we would want a parachute. So a best practice statement would be, if you are jumping out of an airplane, please use a parachute, even though there's no data to support that. So here's an example of this. The specifics don't matter, but just so everybody understands, this was one question from last time. The clinical evaluation and procalcitonin versus clinical evaluation be used to decide when to start antimicrobials in adults with sepsis or septic shock. So here's the recommendation. For adults with suspected sepsis or septic shock, we suggest against using procalcitonin plus clinical evaluation to decide when to start antimicrobials. So how do we get to that? Most people just read the recommendation. How do we actually get to that? So I understand this might be difficult to say. First, we talked about the outcomes before we ever did it that we thought were going to be important. Short-term mortality, long-term mortality, ICU length of stay, hospital length of stay. And though it might be difficult to see, for each of these, a meta-analysis was done, and it shows you how many studies were involved to determine whether there was a difference. There was no difference on any of them. But that's not all. This is not just the evidence. And so here, this is what I call the evidence to decision framework. So we start with, is it a problem? Yes. Identifying when to start antibiotics is incredibly important. Are there desirable effects? No. They were actually trivial. Are there undesirable effects? Those were also trivial. There was truly no difference. What was the quality of evidence? I didn't go through it much in the last slide, but there were only 3 studies. The quality of evidence was actually very low. What are the values involved? No important uncertainty or variability. What's the balance of effects? It doesn't say you should or it doesn't say you shouldn't. It's equal. But that's not all. What are the resources required? Don't actually know. What's the certainty of evidence of the resources required? Again, we don't know. What's the cost effectiveness? There were no included studies, so nobody knows how much it costs. Is there equity? Well, it varies. Let's say that I have procalcitonin in the United States, but Jorge Hidalgo does not have it in Belize. He does, but Gloria Rodriguez has it in Puerto Rico, but Antonio Gandra does not have it in Portugal, wherever you live. And so it varies. Some of us in this room probably have procalcitonin, and some of us probably don't. And is it fair to make a recommendation that only some of us in the world can use and some of us can't? Is it acceptable to use a blood test? Yes. Is it feasible? In some places, yes. But taking apart the fact that I know that Manuel Bayo has a beautiful hospital, if he doesn't have procalcitonin, then it varies, right? And so we take all of that together to come to the recommendation, conditional recommendation against using it, because there's no benefit, but a lot of other things go into the recommendation. So that is how the recommendation is made. So the subgroup does this for every PICO question to formulate each recommendation. Most of them are easy, some of them are less easy, and a couple of them are extraordinarily hard. And then it goes for voting. You need an 80% consensus in order to make a recommendation, with 75% of people voting. And once all the recommendations are agreed upon, the rationale is written for each. In the last one, there are 15 strong recommendations, 54 weak recommendations, 15 best practice, and 9 with no recommendation. Finally, the manuscript is sent out for review to the panel and then to the endorsing societies, also to the steering committee. Everybody gets to make comments. Then it gets sent out to the peer reviewers of the journals. Total comments goes to hundreds of pages, sometimes thousands of pages. So everybody's like, I don't like this. I don't like this. I don't like this. It's an 80-page manuscript. And so somebody always has something that they don't like. And everybody gets to comment. Goes through then, every one of them has to get answered, copy editing, typesetting. And ultimately, from the time we start to the time it's published is 2 years. This assumes that the patient looks like this. So Lauren Source just gave a great talk saying that the patients don't always look like this. So how about resource settings? These are just 3 recommendations. The first is a procalcitonin. But what if you don't have procalcitonin? The next is talking about higher PEEP over lower PEEP. What if you don't have ventilators? What if you don't have oxygen? The next is talking about CRRT. What if you don't have CRRT or even have dialysis? How are those recommendations relevant to you? And that led to surviving sepsis in resource-limited settings. So a new task force with members from resource-limited settings has been meeting for the past year. Everybody comes from a place with relative resource limitations, except for myself and Andy Rhodes from ESICM from the steering committee. Dr. Hidalgo is going to be speaking in part about this. He's going to be speaking much broader, but after I'm done speaking in a few minutes, he's going to be talking about this. The challenges, of course, are that almost all the data in the guidelines is from resource-intensive environments, which is not generalizable to the rest of the world. And how do we give guidance in an environment where almost every question does not have evidence? So let's spend the last few minutes talking about the future. So panels are currently working on the next iteration of both the adult and the pediatric guidelines. The adult guidelines are going to have 129 statements, which is a crazy number. But of these, only 59 are new questions. It's actually less. The others are just carried forward with no new thing. Because more is not more if you can't read the entire document. So if your document's this big and nobody reads it, we're talking to ourselves. So we're actually making it smaller. We're trying to make it from surviving critical illness, not specific to sepsis, to surviving sepsis. So what's going to be new to the 2026 guidelines? There's going to be 13 in our practice statements describing what we do by a survey. So when we don't have evidence for things, people have historically said, what do you do? What do you do? And we've always said, well, there's no evidence. And people say, that's not helpful. You have 70 people who are experts from around the world. Tell me what you do. Even if there's no evidence, that might be helpful to me. And so this time, we're going to have 13 things actually saying, this is what we do. Okay. So aspirational future, improved implementation and broader uptake of the guidelines. Understanding that while the guidelines truly have a global reach, there's many opportunities for improvement. So we want to partner with local societies. There's 10 different local societies in Kozhikode. We want to partner with each of you to assure the guidelines are locally appropriate. I'll bring this up for India, where dengue fever is endemic in much of the world. But I and almost everybody in the panel have never seen dengue fever one time in my life. We want to translate into multiple languages. Yes, it's in Spanish. Yes, it's in Chinese, but it's not in a lot of different languages. We want to make the recommendations smaller because they've become too big. We want to account for different learning styles. I am old and I learn by reading. Most people don't learn by reading anymore. They learn by looking at the internet or short bites. We want to have point of care access and implementation in your health record. We want to have living guidelines. So the current guideline of having new guidelines every 4 to 5 years guarantees that when surviving sepsis comes out, it's going to be incredible. It's going to be comprehensive and evidence-based. It also guarantees that the evidence is going to be out of date. So anybody who heard me talk yesterday heard me say, since this was published, since this was published, since this was published, here's all this new data. And it's not okay to wait 5 years in the year 2025 anymore. There's currently no process to update the guidelines when one or multiple studies are published that would change practice, leaving a recommendation updated. We all know this happens. New studies come out, they change what we would do, but the guideline is stuck in 2021. There's no feasible way to do this for PICO questions, for all of them. And there's no reason to do it because in the last guidelines, 6 out of 93 were upgraded or downgraded, and there were 15 new ones. So you don't need to do everything. You just need to do a few. Um, all right. It's not feasible or advisable to recommend all of them, but there should be a way to do it for a few changes in practice. So I also said in the NIH COVID guidelines, we didn't use grades and the methodology was different, but we revised the guidelines during COVID 70 times in 3 years, and we had over 50 million page views. It is possible when things change for us to be able to change the world. It's possible to put together a small team using grade methodology to assure that you have access to new recommendations and you don't have to wait 4 years to do so. So, in conclusions, the Surviving Sepsis campaign has a wide reach, including guidelines, bundles, research agenda. Even I didn't talk about the bundles, I didn't talk about the research agenda, but it's a wide reach. The guidelines have grown significantly in both size and rigor. Every single time is better than the previous time. Following these the majority of the time do save lives. The new adult guidelines and the new pediatric guidelines are nearly done with an expected publication very soon and a new task force co-chaired by Zacati past president Jorge Hidalgo in resource limited settings. And the future will hopefully incorporate living guidelines, broader implementation efforts, recommendations applicable to the entire population of the world. Muchas gracias.